Hi everybody, welcome to my channel. I'm Stacy, I'm a registered nurse. If you're new here, welcome in. If you're coming back, I'm so glad to have you. Let's talk about the CNA and the RN and the care plan aspect of hospice. Let's talk about it. And if you like what you see here, then I ask that you like, subscribe, and follow for more about hospice, tips and tricks, about facility nursing, about RN, CNA, LPN, anything. I've talked about it. So let's dig in. Let's talk about the relationship between the RN case manager and the home health aide or CNA and what that looks like in hospice. So your RN case manager is coordinating the care of the patient. The CNA is providing cares to the patient. Your RN case manager has to call the doctor for every decision that is being made for the patient's care, for permission or a doctor's order to do certain things for the patient. There are nursing things that we can do as nursing judgment, but generally a nurse is not making decisions without the authority of a doctor to back those decisions up. A doctor is saying yes, no, or providing what they would like for you to do as a nurse, and as a nurse you're enacting that and you are putting it into a care plan for your patient. So those care plans that you do in school, you may not think they're important, but they are a critical piece of caring for your patient. As a nurse, you are making a care plan for your patient, and it needs to be specific to the patient's disease processes, specific to their problems, and it needs to be living. You need to be making changes to the care plan at a minimum every 2 weeks when you're an RN case manager. Because sometimes our patients are sort of static, so the changes that you're going to be making will be small. But generally, if a patient falls, we need to have a fall or a safety care plan in place. If a patient has COPD and they're using oxygen, you need to have an oxygen or respiratory oxygen safety care plan in place. If they have a wound, you need to have a skin integrity care plan in place. And this is where it comes into play with your CNA. If your patient needs symptom management, some of the things that I've experienced as a nurse is maybe not beefing up my care plan as much as it needs to be, or not making it as specific as it needs to be. Something that I've learned over the years doing hospice is that although a CNA is capable, they are not the person that is assessing or making the decision about what is happening with the patient. They are providing the care that has been delegated to them in a CNA care plan. This angers a lot of people, but I promise you that it protects the CNA, because we are talking about scope of practice. We're talking about scope of practice. As a nurse, I cannot titrate morphine without talking to the doctor. I cannot make a decision about titration of morphine, even though I know that's what we're going to do, even though I've done it 20 times, 30, 40, 50, 100 times before. I'm still not allowed to make that decision because I do not have MD behind my name. DO, MD, I don't possess that title. I am a RN. And I do not have the authority to write a doctor's order without a doctor's signature on that order and without talking to the doctor first. In the same way that a CNA cannot make medication recommendations to a patient, they cannot provide wound care, they cannot decide if a patient takes a shower or if they take a bath, if they get a bed bath, if they dress themselves. The CNAs can't decide whether they need oxygen or don't need oxygen. It's not because they're not capable of looking at a person and seeing those symptoms, but it's something that I saw in every aspect of hospice that I've worked in. They have made it very clear. We used to say, when I would write CNA care plans, for example, patient may take a shower or a bed bath if needed. Well, who determines if it's needed? Well, could your CNA determine that logistically in their brain? Could they see if a patient is capable of getting into the shower today? Yeah, absolutely they could. But based on their scope of practice, they absolutely cannot. And that's a hard thing, because I work with a lot of great CNAs that are very smart, very intelligent, very educated. And I, too, as a nurse, have been guilty of not making my care plan specific enough. So as an RN case manager, it's really important that you think about your care plan, that it's specific to the patient's needs, that it's changing with the patient as the patient changes. If a person has a stage 3 wound, also understand you cannot downstage a wound to a stage 2 from a stage 3. Once it's a stage 3, once it's a stage 4, you cannot downstage wounds. Okay, we can't be jumping around with staging of wounds. PPS could change depending on, maybe a patient had a stroke and they're at a 30 PPS this week, and when you go see them next week, maybe they are back at a 50. So that is something that's changeable, a PPS score. But a wound, a skin integrity care plan, once you stage a wound at a stage 4, you can't backstage it. Even if it's healing, it's always a healing stage 4. And if it opens in the same spot, it's a recurrent wound. So when we're staging wounds, we need to be specific in our care plan about what wound care we're doing. Something that I never thought about that I do see some nurses do really well across the board is the CNA needs to know what to do if the bandage comes off. In a nursing home, the CNA is going to come to the nurse and say, hey, patient in bed B, her dressing's off of her bottom, can you come and change it? The thing about working in home health, hospice, is that the CNA is likely going to be there when you are not there to change that dressing. So it becomes your responsibility as a nurse, as an RN, to say what needs to happen if that dressing becomes soiled, it's not intact, or it needs to be changed. You need to be notified as a nurse from your CNA, and you need to have a good comfort with communicating with your CNA and being a supervisor to your CNA. You are supervising the care that they are providing as a nurse. You are a supervisor when you're an RN case manager. You're supervising the care that the CNA is giving to your patient. And so it needs to be specific, and it needs to be easy to follow and easy to understand so that your CNA doesn't have a question about what they're supposed to do in these circumstances. And it's hard to think ahead when you're writing a care plan about every little detail, but you really need to be detailed oriented when you're talking about home care, because things are going to happen that you're not going to be able to address necessarily in the same day. Maybe you've already seen that patient that day and you're 50 miles away and it's 3 o'clock. A nurse that would come on after you needs to know what to do about that situation. If someone's covering for you, they need to know what you've been doing to manage that situation. And your CNA needs to know when to contact you and what to do in situations. So if you have a dressing in place, your CNA needs to know if they can reinforce the dressing, if they should call you and you're going to maybe do a PRN dressing change, or you're going to call the family and have them change the dressing, because as hospice nurses, we are not there 24/7. You know, we're there maybe 30 minutes to an hour, depending on the situation or the care need. And after that, the family is providing most of the care to the patient. So also your care plan needs to be specific as to what the family should do if that dressing comes off. So your wound care plan as a nurse should address how often the dressing is being changed, who's changing it, and who's changing it when the RN is not there. That is really specific. It needs to be in your care plans as an RN. If a patient is on oxygen, it needs to be really specific. Are they on the oxygen continuously? Are they on it as needed? If they're short of breath, who's determining when that oxygen gets put on? A CNA is not determining if a patient is wearing oxygen or not, but they need to know if a patient can take their oxygen off for bathing, for getting dressed, for their cares. They need to know specifically what a patient can or cannot do with their oxygen. If a patient is having a lot of pain and they need to take a medication before their cares, it's really important that you educate the family, number one. You need to really have a good education plan in place with the family members as a nurse. You need to say, and I have said to my patients, hey, your mom seems a lot more comfortable if you give this morphine 30 minutes before I come to treat this wound. So that can be something that you care plan, that the patient should take morphine 30 minutes before the wound. The CNA can call you and tell you if a patient is uncomfortable during their cares, and it's really important that you listen to your CNAs about changes in condition, about wounds that are worsening, about wounds that are developing. It's really critical that you have a good communication with your CNA, because they are sometimes going into the home more than you. And that means that the family is often developing a good rapport with your CNA, and they're going to trust telling your CNA things that they may not tell you when you're there for 15 or 20 minutes. They may tell your CNA. And it's really important that your CNA has the power to direct them back to the nurse, but also if it's something where they can intervene, that they have the provision in how that intervention looks as a CNA within their scope of practice. It's really important that we give our CNAs clear direction for what transfers look like, how cares should look, how many people are providing those cares. If their head of bed needs to be elevated because they have dysphagia and they're going to choke, that needs to be in their care plan. It needs to be in the CNA care plan in black and white so that it's clear as day, so that nobody is looking at that unsure of what to do. Your CNA needs to feel comfortable coming to you and telling you, hey, Papa is not able to take a shower anymore. He can't get out of the bed and transfer into the wheelchair any longer. We really need to change him to a bed bath. Unfortunately, care plans for CNAs do not allow for more than one type of bath. You can put a partial bath in. For CNAs, on days, say the CNA comes, you can word it to say partial bath may be given if caregiver requests, or to be determined by RN. You have to be very specific on who's determining that, because it has to be the caregiver, the patient if they're alert and oriented, and only if they're alert and oriented. If a patient has dementia, they're not going to be able to make those decisions if they're alert and oriented only to themselves, right? It's not that they don't have rights. They have a right, and if they don't want to shower and they're resisting you and they're refusing, they have a right to refuse those things. But as RN case managers, we have a responsibility to know that if a person is refusing a shower on a regular basis and they're not going to get into a shower and they are going to comply with a bed bath, then maybe we need to change that care plan to say that the patient is having a bed bath. Facilities like patients to get up and get in the shower. But if the care plan says that it's a bed bath, that is what the CNA should be providing. It is not up to the CNAs to determine, is this person getting a shower or are they getting a bed bath today? And if the facility wants a certain specific type of bath, it is also up to the CNA to call the RN case manager and say, hey, this facility is insisting that we give a bath. Can you please update the care plan to say how many people should transfer this patient into a shower chair and put them in the shower? And in a facility setting, when hospice comes into a facility, it's really important that the CNA knows who to report off to after they've left, when they're leaving the facility. It should be clear in the care plan who they should report to when they've completed their duties in a facility. Because we are a guest in facilities, and so it's really important that we are communicating with somebody in the facility that we are there, that we did what was assigned to us, and that we document that we communicated that to someone in the facility. So as nurses and as CNAs, it's really important that we document who we talk to when we go into a facility, that we document what we did very clearly, that we document who we reported to when we were leaving the facility. It's really important to always document those things. Even from a nursing standpoint, when you go into a facility, you should always get a name of the nurse who is responsible for the patient, and you should always get a signature from that nurse that you were there, that you were in that facility and that you reported off to them. You need to make sure that you're reviewing the care plan with facility nurses so that they can communicate it to their CNAs, so that these things are all on the same page. Whatever you're doing whatever you're doing for the patient as their hospice team, the facility needs to be aware of that so that we're all doing the same thing. And if the facility has a certain expectation or guideline that we need to be meeting when we come into their home, into their facility, then it's really important that that's care planned for the patient. Care plans are a pain in the butt when you're in nursing school, but they are really critical for determining what cares you're giving to your patient, so that anybody who is taking over care of your patient can look at your care plan and know what you've been doing, and that they know what they should be doing too, so that we're all doing the same things. And that goes for the nurse, the CNA, anybody, because maybe one CNA calls in sick and another CNA has to care for a patient for that day. So maybe that CNA knows that grandma needs 2 people to transfer with, but if it's not in the care plan for the CNA, If another CNA comes in, how do they know? So we have to be really concise in our care plans as nurses so that we can all know what's going on with our patients. Let me tell you, I've been guilty of not putting the clear things in my care plan, and I have been counseled as a nurse many times in my career, young and old, about, hey, this needs to be more specific. So it's not me coming to you saying this as a person who's perfect and who never gets it wrong. But it's really critical that as nurses, that our care plans are concise, clear, and updated, and that we are giving clear, concise instructions to our CNAs for them to know how to provide those cares to the patient. Again, it is not that your CNA is not capable of making those decisions as a person or with their intelligence, because our CNAs are educated, intelligent, and capable, but in their scope of practice, they need you to tell them how to use that oxygen, what to do if that wound care is not on when they come, who to contact when, what, where, why, and what to do at each visit. And that will set you up for success for your patient, and it will give your patient the best care possible, because if you're not there, another nurse can step in and see what you've been doing. And if that CNA who knows the patient isn't there, they will be able to open that care plan and see what cares need to be provided for the patient. The CNA and the nurse are with the patient most of the time, and in a lot of times your CNA is seeing the patient more than the nurse. They really are. And so families will feel comfortable to tell a CNA things that they may not feel comfortable telling a nurse. But it's always important that the CNA directs the patient back to the nurse for clinical questions, such as medication management, wound care suggestions. And if a patient is having symptoms, it's really important that the CNA, and most of my CNAs have been amazing throughout my career at saying, hey, Stacy, your patient has a cough, your patient has a fever today, your patient doesn't seem to be eating anymore. My CNAs have been amazing at communicating those things to me. Your patient's getting a sore on their bottom, you need to come and look at that. Because as the nurse, when a CNA tells you a symptom, you are responsible as the RN case manager to manage that symptom and communicate it to the doctor. CNA, nurse, doctor, it's a very important relationship in healthcare. And as RNs, we can't write doctor's orders, and as CNAs, they can't make nursing decisions. And that's the way it is. I think a lot of my CNAs could become nurses. They've been doing CNA work for a long time and would be great nurses. But it's just really important that CNAs don't step outside of their scope of practice so that they don't ever find themselves in a difficult situation with the state. Same thing for nurses. We can't step outside of our scope of practice. We're not doctors. We can't make medical decisions. We can present clinical symptoms to a doctor, and the doctor can make the decision on how we proceed. That's the way it goes. And that's the thing about education. When you're a doctor, you're trained to diagnose and treat conditions. When you're a nurse, you're trained to assess clinically and report to the physician and carry out doctor's orders. When you're a CNA, you're trained to provide those cares for the patient and do what's in the care plan provided by the nurse. It's the way it goes. It isn't about anybody's intelligence, and it isn't ever an insult to anyone, but we all have a scope of practice that we fall under, and it's really important that we know what the line is and that we follow it so that we protect ourselves and our patients. Have you ever been in a situation where you felt compromised as a nurse, or you were concerned about the care that a patient was getting? Have you ever been a CNA that didn't have a good relationship with your nurse or didn't feel comfortable communicating with your nurse? Have you ever been in a situation where you didn't have clear instructions on what to do with a patient, and even after you talked to your nurse, you didn't see changes? How did you handle those things? Who did you talk to? What did you do? I'd love to hear about it in the comments. And if you like what you see here, then I ask that you like, subscribe, and follow for more. And I thank you so much for watching. I appreciate each and every one of you that took the time to listen to my spiel today. I hope to see you soon. Bye-bye.